Bladder pain syndrome is mainly a diagnosis of exclusion, and as we just discussed, everyone suggested different things, pelvic discomfort, pelvic pain. So how we define a condition has a significant impact on the diagnosis, how it is perceived in the medical community, and even the protocols that are used in clinical trials. Bladder pain syndrome refers to chronic bladder, lower abdominal discomfort, and it mostly occurs upon filling of the bladder. Our guidelines have taken great care in trying to define interstitial cystitis and bladder pain syndrome. It was previously referred as interstitial cystitis, and now the terminology by AUA is bladder pain syndrome. However, they have incorporated the term IC and BPH together in order to allow for recognition for the disease. So as we can see that the AUA describes it as an unpleasant sensation, which could be pain, pressure, or discomfort, perceived to be related to the urinary bladder, associated with lower urinary tract symptoms of more than 6 weeks duration in the absence of infection and other identifiable causes. And we can see the similarity with the other guidelines recommended by EUA and even the ICS committee that they emphasize on the absence of persistent or recurrent pain, or we call chronic pelvic pain, pressure, discomfort. And they also mention the association with other lower urinary tract symptoms like frequency of urgency. And then they emphasize that there is no other COVID infection or other obvious causes of local pathology or any other identifiable disease.
In this particular thing, there are two things is important. One is the low tract symptoms, along with the suprapubic pain discomfort. Along with that, the duration of the disease of the pain or the.
So we have divided the ICPPS, which subtype into classes, those that are present with 100 lesions and those without them. The 100 lesions are represented in the diagrams. Can anyone tell us what 100 lesions are? So they are benign, but the terminology has changed from being described as 100 ulcers to 100 lesions currently. They're not exactly ulcers, it's they don't involve invasion. They are they've got 100 lesions, and they comprise of a small network of capillaries that all radiate towards a central fibrotic scarring tissue. And these 100 lesions are identifiable on cystoscopic hydrodistension. And the thing about 100 lesions is that although they're pathognomic for ICBPS, they're although they're pathognomic for ICBPS, but they're not present in the majority of cases. They're usually associated with more bladder-centric symptoms. And as we can see, these are the different types of cystoscopic presentations that we can visualize in ICBPS patients. These represent the primary lesions with essentially fibrotic patch, and the others, the non-other types, represent glomerulations that are also present in ICBPS. These glomerulations are not specific to ICBPS, but they are also commonly seen. Moving on, to understand better the variety of symptoms that ICBPS presents with, and as we discuss that it's a diagnosis of exclusion, let's discuss a case which will help us understand ICBPS better. So a 45-year-old lady presents to urology clinics with complaints of increased frequency of urination, urgency, suprapubic pain for the last 3 years. Her symptoms have not responded to any medical treatment so far. She has no history of addictions or drug abuse. She was treated for uterine cancer 5 years back. She has 3 children that she gave birth to via spontaneous vaginal delivery, and she reports no complications during the antenatal and postnatal period. The hospital is conducting a research trial relating to ICBPS treatment. Will you consider this patient as a potential candidate for ICBPS treatment? The diagnosis of exclusion, so differentiates first and then we level that ICBPS. Anyone? There were no complications during the antenatal postnatal period. Will you treat this patient for ICBPS? Will you want to enroll this patient? Well, maybe we have to rule out other ones. So let's rule out what our suggestions whatever. So first we had UTI. Why can this not be UTI? Is there any reason? It could be, yes, it's a differential, but is there nothing that's going to exclude us?
radiation cystitis, early history, uretaric stones, TB problem, like GOTB. How you exclude them?
According to our scenario, we can see that the symptoms of frequency, urgency, suprapubic they all go with ICBPS, and then they've been present for a long time, the last 3 years. The fact that they've not responded to any medical treatment so far is also points towards ICBPS. And however, she was treated for uterine cancer just 5 years back, and it's possibly that it's possible that she may have had radiation cystitis. But even if she didn't have radiation cystitis, she didn't go undergo radiation therapy. Having uterine cancer is one of the excluding criteria for considering a patient for ICBPS treatment. With almost all other things with ICBPS, but it is the uterine cancer that rules her out to be considered for ICBPS. Uh, this was made uh, this was made easy for us to select patients because we have a criteria that was developed not just to define the disease but to enroll more and more patients for clinical research studies that allowed us to understand more about the disease and to uh, shortlist patients for treatment. So according to this criteria, the diagnosis of interstitial cystitis mainly relies upon the presence of glomerulations or Hana lesions on cystoscopic examination. As Hana lesions are not present in majority of the patients, the glomerulations are often seen, but the glomerulation should be present in at least three quadrants of the bladder, and at least 10 glomerulations should be present in each quadrant. So that is diagnostic. That helps with diagnosing ICE-BPS. Then according to this criteria, there's a whole list of uh, uh, exclusion that helps us to rule out ICBPS. So that involves patients who have been treated for uterine, cervical, vaginal, or uterine cancers, so those that present with other diseases, those responding to other medical therapies such as antibiotics, anticholinergics, and like someone mentioned, the presence of bladder urinary calculi that rules out ICBPS. And then frequency of urination, but less than 8 times per day, also rules out ICBPS. And then on cystoscopic examination, if the bladder capacity is more than 350 ml, that rules out ICBPS. And then benign or malignant bladder tumors, vaginitis, and even age younger than 18 years rules out ICBPS. So, what leads to interstitial cystitis? There are multiple theories that have been postulated. It is mainly considered a multifactorial insult to the bladder that results in an inflammatory response, or such as the triggering of the mast cells or the defects in the glucosaminoglobulin layers of the urothelial bladder wall that results in thinning of the bladder epithelium. Now, what this does is that it exposes the bladder epithelium to the toxic components in the urine, and that further damages the urothelium. And this is what contributes to the formation of funnel lesions as well in glomerulations, because these are basically ruptured blood vessels that occur after hypertension. Apart from that, other theories have been postulated that result from neurogenic inflammation, and all of this combines to result in a progressive injury to the bladder, and it may present as the classical disease with funnel lesions or without. So far we've discussed that primarily the diagnosis depends upon, it's based upon the definition, and we have to rule out the other causes. So because all of the diagnosis mainly depends upon us, and it is in the clinics that we are able to rule out ICBPS, the first thing that we the first thing that we do is that we take a detailed history of our patients. This is what has the most significant. Uh, this is what leads us to the most significant differentials. It is very important to establish trust with the patient, Because usually when we see them in clinics, these patients have been to multiple doctors, they've been through many treatments, they're usually depressed or upset or have been in pain for a long time. You need to explain to them why is it that they should trust you and why is it that they should follow your treatment that you are offering and what you are looking for. It is very important to explain to the patient since the beginning that this is something chronic and it will not help them if it will not help. You will not be able to help them ideally if you cannot build their trust and be able to explain to them that they need to be connected with you throughout the course of treatment, and you need to give them logical reasons as to why you are considering some diagnosis and what is it that you are not considering.
So what are the questions you ask? Mm.
What would you want to know about in the history? Duration of? That's one of the most important questions that people ask. Because classically, these patients describe themselves as having lot of pain, mainly felt in the lower abdomen, and it's related to filling of the bladder. And most of the patients report some relief after passing urine. What makes it confusing is that patient usually presents with vague symptoms or symptoms that overlap with many other diseases. So they may have pain not just in the superphysic area, but they may complain of urethral pain, vaginal pain, or even feel tense knots in the perineal region. So, taking a detailed history is one of them.
What are the specific points asked
Which we try to rule out other diseases.
for multiple bladder surgeries? So the bladder becomes small sized. So the patient has increased frequency. Or you take a medical history. For example, this patient took kids' minds. So definitely the frequency. Previous gynecological surgeries. That are the history.
Taking a gynecological history is very important in these patients because ICBPS tends to overlap with many many other disorders such as hypopelvic fluid dysfunction. And patients usually present either with overlapping disease or one of the two. How will we examine this patient? What would we be focusing on? Patients usually have lower abdominal pain, so abdominal examination first. And what else? Pelvic examination is very important. Why would it be important for carry out a pelvic examination? What are you looking for? Only for lungs. So since we were talking about overlapping disorders, pelvic examination helps to rule out pain associated with other perineal pathologies. It could be lapse pelvic musculature, or it could be other diseases affected. A thorough neurological and psychological exam is also important for these patients. What investigations would you like to carry out? That would give us an idea about any existing infection, even without CBPS, and anything else. Bladder diary, wedding diaries are diagnostic. They're very characteristic for patients with ICBPS. What would you expect to see on an FPC chart walking by an ICBPS patient? What would you like? Do they have high volume voids or low volume voids? The bladder capacity is more than longer. It could be excluding accidents. But what classically means 50% when they have increased frequency urination, but they present with smaller volume voids. They would never have 200 or 300 ml per void. They would be passing small amounts of urine very frequently. This bladder is irrigated by the bladder, so as soon as the bladder fills, we pain or discomfort and they have to do. So small liquid voids, small volume voids, classically seen with ICD patients. Anything else we would like to investigate? Let's discuss this a little bit with this, understand this better. But I would, once we've diagnosed the disease, how would you proceed with treating the disease? What is something that comes to mind that might help the patient? This patient has been in pain for a long time. They've tried all sorts of treatments. They're distressed, they're upset, they have come to SIUT, the biggest hospital in the they expect better results. What are you offering them? Four things first. We counsel the patient on how they can cope with such chronic pain. Like dietary modifications, avoiding caffeine, avoiding citrus foods, or spicy foods has been proven by research to decrease the symptoms of pain in patients, and also offering psychological support is important. We also recommend the pelvic floor strengthening exercises, and they help in improving these symptoms. So, what do you consider for the pain? This patient is already taking lot of pain. So once you address the patient's psychological distress and you help them cope with the disease, with your medication, you are mainly targeting to improve the pain, to address increased urinary frequency so they can have a better quality of life. And we try to target the defective epithelium that is created by ICBPS. We try to improve this because that results in improved pain and improved symptoms for the patients. In foreign medications, we consider the use of amitriptyline attacks as a painkiller and helps with neuropathic pain, as it's proven to be beneficial for ICBPS patients. And also because we discussed that ICBPS is often triggered by a mast cell response, motility gas also plays a role in helping the symptoms. What we can do to improve the defective barrier is use petrozan polysulfate, comes with the name of Alveron. It helps in rebuilding the bladder lining, which decreases the effect of noxious substances on the lining and then provides relief from pain and discomfort to the patient. However, it comes with the side effects of reversible alopecia, diarrhea, nausea, and rationally. What has been proven to be even more beneficial in patients with ICBPS is intravesical instillation of drugs. This is targeted therapy towards the bladder and helps relieve the bladder-centric symptoms. So it will not cure the disease, but it will help provide relief to the patient. And this is most optimal for patients who have bladder-specific pain, not pain that is radiating to other areas. It would address the bladder pain, and we'll have to do something with the associated pains. So, what is it that you will instill the bladder with that can help with discomfort? 15 is one drug. And what else? Anything that provides energy. So, multiple drugs have been tried and tested, and they are used in various clinical practices. This is a medical regime that is used at Al Shifa Hospital in Islamabad. They've been using this for a long time, and patients they consider to have ICBPS. They make a cocktail of xylopine, sodium bicarbonate as a carrier, injection heparin, and normoxide to increase up the dose. And you instill this into the bladder for 30 minutes, clamp the Foley for 30 minutes, and you repeat this weekly for 12 weeks or bi-weekly for 3 months. So different durations have been proposed in different research studies. This is what our colleagues at Al-Shifa Hospital are currently practicing with. They haven't published any results with their studies, but they're carrying on. Uh, there are enrolling patients in studies, and we will be able to see these results. But we already have proven benefits, especially with lidocaine installation. It provides analgesia. The thing with the bladder installation is that it's not curative, but it provides symptomatic relief. But these therapies need to be repetitive. They provide symptomatic relief for a period of time, and then you have to keep the patient on board that they have to come for uh, repeated therapies. And in the long run, patients have even responded to better quality of life on 3 month or 6 month follow-ups, or even with 2 year follow-ups.
Dr. Abbas, Dr. Abbas, Do we use this type of regime in our setup? Hmm. So technically, it's a very easy to give this regime. So can this be done at here? First, what's the problem?
Problem is diagnosing the case. It's not about these drugs. It's about the proper patient. Um, how many interstitial cystitis have you seen in the past 10 years, 20 years? अच्छा, देखिए उसमें बताऊँ बात क्या है, ऐसा नहीं कि मैंने देखा आपने नहीं देखा किसी ने देखा, हो सकता है somebody has got a loud thinking के चूंकि मैं सीनियर हूँ इसलिए मैंने सब कुछ देख लिया. No, that is not the case. Even a junior person can see it, provided you start reading these chapters, which are not so important chapters, earlier in your uh, residency. So earlier you pick up all these things which are not so common, or maybe they are very common, but they are less seen or less reported. And when you do cystoscopy, these things should be at the back of the mind that you might uh, get a picture, a flicker of an ulcer in the bladder. Try to decompress the bladder, try to see whether these ulcers weep or not. Weep means ये क्या रोते हैं या नहीं. So there are certain ulcers that are weeping ulcers. These ulcers, the Hunter ulcers, are weeping ulcers, and this is pathognomonic of interstitial cystitis. Uh, Earlier, when we have started our own journey of residency, um, the glamorous cases of URS and things like that were taken care of by very senior people, and we were not allowed in that. So we were allowed to do only these cases, the Kachara cases. So we try. We means me and my colleague like Saeed Abdi and others. We always want to put some kind of a money or a value into what kachra is considered to be. And that kachra is actually something which is very valuable. It's gold dust. These are all gold dust because once you start diagnosing these cases, you will never forget. Then Saeed has got a chance of practicing 20 years abroad. I didn't have that chance, but I have that chance of doing a little bit somewhere else also out of this country. And I've seen that in the West, these cases, interstitial cystitis, they are very, very common, particularly in white population in Scandinavian countries as well as in Australia. And if you go into any ward, urological ward of those countries, you will find almost 30% cases, younger people, middle aged, between 20 to 40, with these kind of problems. And they do have hydrodistension, they do have these installations, and they do have a lot of other things just to treat those conditions. We haven't seen it. Nobody wants to teach us these cases because we have got something else to talk about. But these are very common. These are here in our population. They are overlooked. They are less reported or not reported at all. If somebody is interested, they start seeing it. For instance, in Shifa International, since Saeed Akhtar Saab was there, Saeed Akhtar Saab has got his training in America. So when he came back to Islamabad, he has got a lot of cases just because the reason that he has got a mental picture of interstitial cystitis, how it presents on a cystoscopy. So if somebody amongst you, the whole lot that is sitting, whether junior or senior, no matter, if the picture is in your at the back of your mind that these ulcers look like this on the on a cystoscope with a distended bladder and a decompressed bladder, you will never forget these pictures and you will start diagnosing your cases. So it's about application of knowledge and a little bit of interest.
So we have to work for our history taking and spending that investigating. Oral cyclosporine has been recommended in cases where patients do not respond to bladder installations or oral therapy, and it often comes with a significant improvement in bladder capacity, body volume, pain, and therapy frequency. Moving on to surgical treatments, we offer bladder filtration to the patients. The bladder filtration is targeted at other lesions only. They are not recommended for all patients with ICBPS. It is said to provide symptomatic relief of pain and discomfort once the other lesions are filtrated. However, it comes with the side effect causing fibrosis in the bladder. It provides temporary relief, and the patient may need frequent sittings, and that may result in fibrosis of the bladder, as we can see, which will end up uh, in a fibrotic small capacity bladder. So this is something that we have to use very, very carefully if we are often for this.
Right. I just want to add one point. When you start taking interest into this subject of bladder reaction to a lot of different things, um, you see that there is a similarity between interstitial cystitis picture, cystitis cystica glandularis, for instance, or cystitis ureterica. So, ureteritis cystica. So all these things, they do converge into one singular point, and that is fibrosis. Whenever there is fibrosis, if it happens in the bladder, the capacity is compromised, the capacity is squeezed, and your bladder is less distensible, which leads to a lot of symptoms. The same goes with interstitial cystitis. It tends to constrict your bladder distensibility. Um, the treatment in both the conditions is at some point in time, you've got to take the decision of augmentation cystoplasty. So these things do culminate into one common denominator, and that is fibrosis. And the thing that can take away that kind of problem is reconstructive surgery.
Or better to or exercise between the sections. So we perform the suprachiasmatic cystectomy along with the augmentations. We call it substitutional augmentation. Physical trigon and the help of the iron, we need the augmentation. We call it substitutional augmentation.
आप पूछ सकते हैं कि what's the logic behind substitution and why not complete?
Can I know?
Why are we not going for a complete cystectomy?
यूरेथ्रा तो दोनों में रहेगा, तब यूरेथ्रेक्टमी थोड़ी कर रहे हैं. What do you want to preserve?
I want to preserve the normal anatomical way of passing the urine from the kidney through urethra and outside of the body.
It's the way you pass urine, it's the way you control urine. What is more important?
Control urine.
हाँ, तो ये बोलिए कि you want to preserve the sphincter complex. Because this is not a complete sphincter. It is not a sphincter like, for instance, a circle of fiber going round and round. This is a complex structure of a sphincter. So we call it a complex sphincter. इसको आप जो है ना वो preserve करना चाहते हैं, and that is the reason why you want to preserve trigon as well as things below the trigon, and you do supratrigonal cystectomy just because the reason is more redundant है. It's not going to play for you. It will, if you just leave it behind और उसके अंदर आपने augment कर दिया, तो बास आप आपको बताएंगे, it will act like another diverticulum, a big diverticulum, which will never empty itself. You have to do thread maneuver. Even then, it will never empty. So I'm not part of your team, but I know a little bit.
With surgically managing these things, we do have multiple options, but we have to be very, very careful when we select patients for surgery. Even with surgical management, definitive results are not guaranteed, especially when we're leaving a part of the bladder behind. There is a possibility that the symptoms of pain and discomfort will weaker, and the situation will be the same for the patient. We have to be very, very careful when we select these patients for surgery. We have to counsel them thoroughly. We have to let them know about the pros and cons and the impact it may or may not have on their quality of life. But we cannot step back from surgery as a treatment just because just because it may not be 100% beneficial. There have been cases of reported suicide by patients of ICDPS because their pain was not relieved and they were distressed by the pain. So be very careful when you are selecting your patients, but don't hold back on the treatment.
So, did we say something about the etiology of the whole process? Its status?
This is also recommended in our EMA guidelines. It's strong recommendation that patients who have not responded to intravenous therapies, so trigonal and bladder wall injection of Botox with hydroprescription has proven to give good results. We even put these patients for undergo hydroprescription for diagnostic and therapeutic purposes, but we have to be careful about bladder wall.
So you see, when Botox is being used for the purpose of cosmesis on the face, it's the same Botox. What does that Botox does? There is no smooth muscle on the face, or is it? These are all skeletal muscles. आपके facial muscles सारे skeletal muscles हैं. जब आपके wrinkles खत्म करने के लिए on your forehead, not on your forehead, my forehead, जब खत्म करने के लिए हम इंजेक्शन लगाते हैं तो वो Botox क्या करता है? So it's not anticholinergic, it's something else. Will not want. So it's a neurotoxin, right? लिखा हुआ है ना, toxin भी लिखा हुआ है. So it has got a neurotoxicity, which means that it blocks the saltatory conduction. आपने जो बात की है ना, वो तो आप इम्तिहान दे रहे हैं इसलिए बात की है कि आपने तो एक MCQ पास करना है. मोटर एंड प्लेट की बात कर दी आपने. मैं तो पुरानी बात कर रहा हूँ. मैं बात कर रहा हूँ कि काम कैसे करता है. तो ये सॉल्टेटरी कंडक्शन आपके लिए आपको जो है ना फर्स्ट ईयर MBBS में जाना पड़ेगा. व्हाट इज दैट सॉल्टेटरी कंडक्शन? तो ये जो है ना ये उसको ब्रेक करता है उस पूरे साइकिल को. सो व्हेन देयर इज नो मसल कॉन्ट्रैक्शन, then your face becomes a mask face, no wrinkles, and you see that there is rejuvenation of facial expression. It's not facial expression that is rejuvenated. आपके पास कुछ होता ही नहीं है, expression less हो जाता. So यहाँ पे भी यही हो रहा है कि when there is a lot of compromisation in the bladder capacity because of active involvement of nerves, whether they are sympathetic or parasympathetic. So these nerves are made non-functional just because of this drug, and it is being delivered by needle, that is a deflux needle, submucosally. So this is very important because these questions are actually in your exam paper somewhere.
So we will be able to offer treatment when we're able to diagnose ICD. So let's see how we have. So a 48-year-old lady with no performance seen in the urology clinic with complaints of suprapubic discomfort for the last 8 years. She describes the pain as being associated with the desire to urinate, and she rushes to relieve herself as she feels urine loss. She complains of increased frequency during the day and night time. Multiple rounds of antibiotics have been completed with women. What may be the most likely diagnosis? ICDPS, UTI, or active bladder virgin, or any. Okay, why are you considering it to be ICDPS? All of that comes to ICDPS. Any other answers? Anything else? Everyone thinks that it's ICDPS. ICDPS. People who presented bladder syndrome before. What's the diagnosis? Why not UTI? Why not overactive bladder? Does overactive bladder present differently from this? Discomfort is spatial discomfort. It's not saying that. You just guide the pain as a protein discomfort. Okay, let's say she's saying discomfort. Your big pressure field. Why could it be a possibility? Why is it discomfort? Why is it discomfort?
Okay, thank you.
The answer is overactive bladder. Urgency is not specific for ICDPS. Fear of urine loss, not ICDPS. Fear of urine loss is overactive bladder. Thank you.